Chennai. Thank you, GVK boss. Thank you, chairpersons. And the topic is very interesting because I'm going to talk about disease-modifying therapies and how the DPP4s have actually helped in modifying the treatment of type 2 diabetes. Now, the whole incretin-based therapies came around 1.5 decades back, and it actually changed the way we were practicing glycemic control. And paradoxical high glucagon, we realized, is a pathophysiological defect in patients with type 2 diabetes. And how these incretin-based pathways work on the beta cells, they slightly work differently from the secretagogues we had till then and the secretagogues we have till now, because they act through the cyclic AMP pathway, and they also have something called as glucose competence concept. That is, they stimulate the pancreatic beta cells to secrete insulin only in the presence of glucose. So in that respect, when they came in 1.5 decades back, they were insulinotropic, one of the first insulinotropic agents other than a TZD or metformin we had then, and a secretagogue without hypoglycemia. So that was the advantage that a DPP4 inhibitor came up when it was launched 1.5 decades back. So I'm not getting into the evolution of gliptins. I'm going to just speak on 2 or 3 studies which actually helped us understand how DPP4 inhibitors work and how they have changed the management. Now, when they came in, and now after 1.5 decades, we can safely say that they do not have any drug-to-drug interactions, they do not have any serious adverse drug reactions, and they're very safe to be used in terms of patients, whether they're elderly, young, or middle-aged. The study which actually changed a lot of mindset and actually contested guidelines was the Verify study. Now, the background to the Verify study also, we had a lot of evidence suggesting that DPP4 inhibitors had a huge durability as far as glycemic control goes. And you have a 4-year monotherapy study with sitagliptin, you have a 7-year sitagliptin plus metformin durability study, which said that the glycemic control with these particular molecules are much more durable than certain other secretagogues, which may make the sugar go down very fast, but the durability is a question mark. Verify was a multinational, multi-ethnic study, 2,000 people, 34 countries, 254 centers, India well represented, almost 10% were from India. What was the Verify study? Most of the patients in the Verify study had glycemic control close to 7%. But what we were trying to achieve is that whether the sequential add-on of drugs that we follow guidelines about, that we add patients on metformin, and when metformin fails, when we go up to the highest dose, we add on another drug. When that drug fails, we add on a third drug. Is that the right route to approach in patients with type 2 diabetes? Or whether around a decade back, it was also told that using multiple disease-modifying drugs at submaximal dosage, if you can introduce polytherapy earlier on in diabetes, probably it can treat multiple pathophysiological defects in patients with type 2 diabetes, and probably the control will be better. So here you had patients who were newly diagnosed and who were very close to their target control of 7%. One group was put on a combination of metformin plus vildagliptin. Another group followed guidelines that you put patient on metformin, and when metformin fails over a period of time, you then add on a DPP4 inhibitors, and we see over a period of time how this actually rolls out into a strategy. So what did it tell us is that there was a 49% significant reduction in the risk for time to initial treatment failure with combination therapy with Vilda plus metformin over 5 years. What it said is that if you add 2 drugs at a time, even when patients are at close to control, the treatment failure takes almost close to 60 months. That means almost the first 5 years of patients with type 2 diabetes, if you just shut your mind and put them on a DPP4 plus metformin, almost 50% of them would remain in control. Patients on metformin tend to fail very, very early. The median time to failure for metformin was 156.9 weeks compared to combination therapy, which was almost 60 months. This is important with the risk for time to second treatment failure. So after the patient fails to metformin, he was sequentially added on to the same drug, vildagliptin. So at one time, you had patients who were added on to vildagliptin plus metformin from day one. The other cohort had patients who failed to metformin and vildagliptin was added on. And to see with the second treatment failure. And surprisingly, there's a 26% reduction, significant reduction in second treatment failure, which again went in favor of the combination, which tells us that if you add a combination early, it sustains the durability over a period of time, rather than following a guideline where you add metformin, then add a combination. Probably the pathophysiological effects that the combination has and the multiple pathophysiological defects it treats with the combination earlier on provides sustainability over a period of time. And let's look at the Indian subset. Indians, we had almost close to 160 patients. Risk for treatment failure, initial treatment failure, again it was better than the global. It was 53% as compared to initial treatment failure. Median time to initial treatment failure was also longer. Our second treatment failure, which is almost 26%, this was 58% in India. Now, if you look at recent articles which has come about how incretin base and especially DPP-4 works better in Asian Indians as compared to the Caucasians, there are a lot of data suggesting that probably the increase in adiponectin, which DPP-4 does, probably increases or betters or reduces the insulin resistance, and that's the reason that DPP-4 inhibitors work better in East Asians and Indians as compared to Caucasians. And there's a lot of data to suggest that the DPP-4 works better and the GLP-1 may not work as well as DPP-4 in patients with type 2 diabetes in India. So the Verify actually made us believe that we should start combination therapy early, and you may take 60 months for it to fail. That's a good amount of time to keep patients under control. The next disease-modifying trial in DPP-4 was the sitagliptin trial, the TICOS, one of the most well-done trial from the Oxford group, a big occasion, and the background, we all know what happened in 2007 and 2008. What it wanted to show was just show non-inferiority to other gliptins. And if you remember, the Sevotimi had come in and it had already shown there was a slightly increased number of events of heart failure with that drug as compared to this particular DPP-4 inhibitors. And as compared to many other cardiovascular outcome trial, the TICOS looked at a 4-point MACE as compared to 3-point MACE with many others. So they also had hospitalization for unstable angina. Not getting into details of this particular study, but around that time we also had a lot of cobwebs in our mind that probably pancreatic cancer, pancreatitis, all this gets affected because of DPP-4 and other incretin-based therapy. And again, here you can see that sitagliptin versus placebo, there was no signal towards pancreatitis or pancreatic cancer or any other malignancy as such. Even in terms of adverse events other than the upper GI dyspepsia, nothing was seen. In terms of the primary composite endpoint, it was completely linear, so there was no signal towards any cardiovascular toxicity or any signal towards any cardiovascular event for DPP-4. And again, if you look at heart failure, which because it had come on the background of saxagliptin, and again there was no signal towards any heart failure with this particular molecule. The hospitalizations for heart failure with placebo versus sitagliptin was very, very similar. And even if you look at any kind of pre-specified analysis, especially it depends on region, because we know that EMPA-REG was actually driven by Europe and part of Asia, and here you see that there's equal weightage to all particular region. There was no region which was driving this particular study. Secondly, any pre-specified, whether patients had a background of heart failure, whether patient's blood pressure was higher, smoking or medications or any other drugs what the patients were using had no impact on the cardiovascular outcome. So it was purely the study. So the primary composite endpoint, it was non-inferior, not superior. For the secondary endpoint also, which was CV death, non-fatal MI or non-fatal stroke, again sitagliptin was non-inferior. The HHF did not differ between sitagliptin and others. And hypoglycemia again did not differ between sitagliptin and placebo. So again, when we put verify and we put both these studies together, TCOS, we see that there is a group of molecules which is cardiovascular safe, which is durable and controls patient in the initial years of diabetes. Our chairperson already alluded to this new parameter that we are looking at for the last decade or so, and time in range has come into a parameter that we are actually closely monitoring. And I'm not going to go into molecules per se, but glycemic variability has been one surrogate marker of diabetes which we have always forgotten, because till date we don't know what's a good HbA1c to prevent chronic kidney disease or cardiovascular death. Probably the ups and downs of blood sugar may have an important outcome as far as patients and especially cardiovascular goes. We still don't know, but there have been very few outcome studies, one being the flat sugar study published 7 years back, which showed that lesser glycemic variability has an impact because it reduces a lot of inflammatory markers and also a lot of other markers in terms of glycemic control, even if we achieve the similar glycemic control. So we know what is glycemic variability, and I just want to go to time in range and the J Victoria study, which is a study of vildagliptin versus sitagliptin, and again done in Japan. That's the reason the dosages are different, but you will see that this is the only good RCT which compares to gliptins, and here vilda scores over sita in terms of glycemic variability, and lesser glycemic variability when we use vildagliptin versus sitagliptin in a Japanese Victoria study. Important to note is that all these drugs have fantastic durability, have lesser glycemic variability as compared to many other molecules. That's the reason whenever a patient is fasting, whenever a patient undergoes any kinds of religious, non-religious fast, these drugs are good to use. Secondly, also, the chances of hypoglycemia is almost close to nil. This is the only group of molecules which have done studies in the elderly. When I mean elderly, is patients more than 75 years of age, and that's a group which is not usually included in many studies. And here you see that with the use of DPP4 plus metformin, they have been very safe in that bracket of patients also. So durability, good control, no hypoglycemia, insulinotropic, durability of control, and no glycemic and very little glycemic variability puts vildagliptin and sitagliptin right up there as a disease modifying agent in the treatment of type 2 diabetes. Thank you all for a patient hearing.